Well, thank you all for joining our webinar today, Designing Value-Based Payment Innovations for Pediatric-to-Adult Transitional Care, Lessons from the Field. And we're delighted to have leaders from the Florida Department of Health's Children's Medical Services operated by Sunshine Health and Texas AmeriGroup Star Kids Plan, as well as our funder, Holly Henry. And I want to just introduce these guests. Holly Henry directs the Packard Foundation for Children's Health, Children with Special Needs program, and has helped to guide a series of our funded efforts on not only on value-based payment, but also most recently on quality measurement. Ray Wilkerson directs the Provider Payment Innovation for Sunshine Health State Health Plan, which is one of the largest health plans in Florida and a subsidiary of Centene Corporation. And this plan is Florida's Department of Health's Children's Medical Services Health Plan. Erin Head is AmeriGroup's Executive Director for both Star Kids and Star Plus programs. And these are Texas Medicaid program plans for children and adults with disabilities. And I also want to introduce my colleagues, Patience White, the co-director of Got Transition, and Annie Schmidt, who is a research and policy associate working on all of our payment activities. I also want to acknowledge the voices of the parents of transition-aged youth who have been part of this project, Elisa Ware, Elizabeth Tucker, Rosalba Caleros, Yetta Myrick, and Jennifer Pretty. Thank you all for joining the call. I am happy to turn it over for some welcoming remarks to Holly Henry from the Packard Foundation.
Thank you, Peggy, and welcome everyone to this webinar. Again, my name is Holly Henry, and I serve as the director of the Program for Children with Special Healthcare Needs at the Lucile Packard Foundation for Children's Health. Our goal at our foundation is to improve the healthcare system for children with special healthcare needs and their families. We do this by focusing on three specific areas within the system. First, standards, understanding the importance of setting standards for systems that are serving children with special healthcare needs and their families. Second, care coordination, supporting families as the primary care coordinator and helping engage providers and families in effective communication and strategies to ensure their children have access to what they need. And finally, engaging families. So I'm thrilled that Peggy mentioned the family leaders and experts that have contributed to this work, recognizing that families know more about the healthcare system than any of us, and they know what is working and what is not working for their children, and they need to be at the table to share their expertise. So the key component of improving the system of care for children and youth with special healthcare needs and their families that we're going to talk about today is addressing transition. This is a huge topic for families. Many start talking about it as early as age 13 or 14, thinking about what will happen to their child as they age, as they transition perhaps into a different health insurance program, and how their needs will be met into adulthood. So I just want to acknowledge and thank everyone for taking on this topic. Transition is really, as I described, a key component of continuity of care for children as they become adults. And it is vital for both the pediatric health system and the adult health system to think about this issue. And it's important for payers across the spectrum to be partnering, to make available recommended transition supports for youth and young adults and their families as they age. So really just thrilled to be working with this team. As Peggy mentioned, we've had a partnership for almost 10 years, and also thrilled to hear from two large and innovative state programs that are early adopters, of this crucial set of services for children and families. So I know that's really what you want to hear about, so I'm going to turn it back to you. And thank you again.
So much, Holly. If we could turn to the next slide, please. Our team and the two MCOs have no disclosures, although I did want to make note that In addition to the funding of this work from the Lucile Packard Foundation, our organization, the National Alliance, also operates GOT Transition, which is the federally funded National Healthcare Transition Resource Center. Next slide. So the aim today is to give you a quick overview of a new guide that we put together on designing a value-based payment initiative. And you'll hear from two large Medicaid MCOs about their process in designing a pilot. And we're looking forward to having an audience exchange. So the next slide. Not long ago, we asked a series of Medicaid payers why care about healthcare transition. And there are quotes here, I think, sum it up about the importance of aligning transition with the triple aim, that when it's not done well, increased costs happen, and that value-based payment is a natural lever to help encourage innovative solutions. Next slide. So just a little bit of background here. Transition-aged youth and young adults, and we count them ages 12 through 25, they're 20% of the US population. And national estimates show that between 25 and 35% have one or more chronic conditions, and an estimated 6% have a disability. And the National Survey of Children's Health shows that the vast majority are not receiving transition preparation from their healthcare providers. And you can see below, for those with chronic conditions, 77% are not receiving anticipatory guidance on this, and 82% among those without chronic conditions. Next slide. So when you think about making the case to payers and MCOs, we always pull up the clinical report, which was produced in 2018 by these three major professional organizations. And they too call out that transition should happen between 12 and 26 for all youth. They specify that transition includes the planning period, the actual transfer, and the integration into adult care. And what the recommended approach for doing this is GOT Transition's 6 core elements, which are very customizable and free. And again, you can see the clinical report pulled out special populations, and you're going to hear some of these examples on the call today, and also the great need for payment innovations. Next slide. So what we have today is we're just releasing a new value-based payment guide to help payers and MCOs and public health programs, pediatric and adult systems to design a value-based payment initiative. We know that we're all in this in a very early stage, so this is really helping to plan. And so over the past 2 years, with funding from Packard, we provided free technical assistance to several state Medicaid agencies, you can see here, Medicaid MCOs, a large integrated healthcare system, and public health Title V programs in these 3 states. And the guide actually features 4 of the Medicaid MCOs, and 2 of them you're going to be hearing more about today. Next slide. So this is coming up. The next slide is kind of a busy slide, but just to give you some overview of it, you can see the pilot population, and all of these were those with chronic conditions, and for the most part, Medicaid population. The healthcare transition activities that were addressed, for the most part, were around transfer and integration into adult care. The time period varied from a year to 24 months, and there was a mix of payment methods for the most part, using enhanced fee-for-service and value-based payment. And again, you're going to hear more from each of the plans about this. And then the quality measures that typically are planned for are the feedback survey. Next slide. So the first step in the guide is figuring out, well, what is the healthcare transition intervention you want to focus on? And we lay out different options. So you might want to focus on all 3, planning, transfer, and integration, or just on transfer, and integration. Again, the timing will vary depending on what's chosen. And again, with our 2 pilots today, you're going to hear a picture of what's involved in a transfer pilot. Next slide. And so in each one of our steps, we give an example. And here the example was from Intermountain Health. And they elected to focus on both planning and transfer for youth and young adults with congenital heart disease. And you can see it's a large age span, and it's between 1 year to 2 years. So in the guide, we lay out what did they do in terms of the steps for planning. And these are the kind of the clinic process steps. And if you go to the next slide, what were the steps involved in actually transfer? Again, we're trying to be as practical as possible, giving ideas of how given systems have put their pilots in place. Next slide. So the next step is thinking about your transition age populations for a value-based payment pilot. Again, there's many options you can think about. And as are the examples in our guide, really focus on those with chronic conditions. But you could also think of particular eligibility groups, or in the case of Florida, those who are in a Title V special needs program. And then we give out other examples. For example, thinking about those who are 21 and older, who are still in pediatric care, who might need expedited attention. But whatever the population one elects to start with, it's been our experience that you want to start a pilot with a population regularly using care. Next slide. So the example that we give here is looking at a population with intellectual and developmental disabilities. And we lay out the particular data that would be important to collect at the baseline, looking at individual years, in this case, between ages 16 and 25. And then we encouraged collecting what percent are with a pediatric provider, an adult provider, or have no primary care provider. And then looking gaps in ambulatory care, those with an ER visit, and those with an inpatient hospital admission. Next slide. So using that baseline data, it's then possible to think about performance measures going forward. So you could think about increasing by whatever percent the number of young adults ages 22 to 26 being seen by adult primary care providers. Again, we give out several examples of things that you might want to consider reporting on in such a pilot. Next slide. Next up is step 3 on selecting accountable pediatric and adult sites. And I think a critical question people always ask us is, well, should we start with primary care or specialty care or behavioral health? And we generally encourage starting with primary care, but clearly there's no right answer. And in the end, we want all of them to have a systematic process. So oftentimes people say, how can I find interested adult sites? And we lay out some suggestions for ideas about finding adult providers. I think that probably the most interesting one is looking for adult clinicians who have completed their training in the past 10 years, because oftentimes their practices are not as full as those who have been out for 20 or so years. Next slide. So step 4, and you're going to be hearing from the Florida team a little bit more about their selection process. Now, step 4, kind of the guts of this work, is thinking about what is your value-based payment option and your fee-for-service options. So we list out several examples of value-based payment options that could be considered. And on the call today, you're going to be hearing from AmeriGroup about what they did for the per member per month. We also put in there the direct payment to consumers, again, thinking about how youth and young adults are not the greatest users of healthcare, and this might be kind of a complement to other value-based payment methods. Next slide. So then the fee-for-service options, we lay out a set of healthcare transition services and crosswalk them to available CPT codes. Again, this is not a perfect world where all payers recognize all these codes, but certainly there's a lot of potential to for improvement here. So next slide. So with every value-based payment effort, thinking about quality metrics is critical. So we lay out a series of utilization measures that are important, and we have a set of outcome measures as well. So again, giving you some idea of the percent of individuals ages 18 and older who made their initial adult primary care visit within 6 months of the last pediatric visit. So clearly one could just simply use your claims data to look at that, that measure. Next slide. And so then another example of a measure of experience is looking, Florida is going to be using the Gut Transitions feedback survey tool that we have. It's a simple one-pager asking the young person about their experience in the transition process. And that this is typically given after the initial visit on the adult side. Next slide. Now, the last step is actually getting started. And here I think that over and over again, the senior leadership buy-in is so critical. And I think you all wish to be in an MCO with the senior leaders that are on this call today, but their role in this is so foundational. And then forming an improvement team with your pediatric and adult sites, and then deciding on your intervention that you're going to pilot and the workflow that will be established, and ensuring that you get feedback in advance of the launch. Next step. So we next lay out on the pediatric side a sample timeline that could be considered, keeping in mind on the pediatric side that the first 3 months are really about startup and getting your tools customized, and then a couple months of inviting your young adult patients. Again, during this time of COVID, it's always a challenge of people wanting to make a shift, but and then on the pediatric side here, looking at the months 6 through 15 to actually do the transfer pilot, and you can ending in an 18-month period. And next slide. And on the adult side, similarly, they're doing their startup work over the first 3 months, customizing their tools, their processes, and getting information from the pediatric sites about the number who will be transferring in. And they, again, likely will be receiving the new young adult patients between months 9 and 18. So there's some overlap there between the pediatric and adult time period. Next slide. So I'm going to be happily turning this over now to our, starting first with Ray Wilkerson. These are we've asked these, and going to Aaron Head, these are the MCO questions that we asked them to consider. And so I'm delighted to turn it next to Ray. I think we have maybe one more slide about no, it's at the end. Okay, Ray, it's all yours.
Thank you so much, Peggy. I really appreciate that. Good afternoon, everyone. My name is Ray Wilkerson. I am the Director of Provider Payment Innovation for Sunshine State Health Plan. It's really an honor to be here this afternoon talking to you all. And I'm really here representing the Florida Department of Health Children's Medical Services Health Plan operated by Sunshine Health. So a little bit of background on the Children's Medical Services Health Plan. The CMS Health Plan is operated by Sunshine Health on behalf of the Florida Department of Health. CMS is one of Florida's largest pediatric-only health plans. They have more than 25 years of clinical care experience. and they serve over 91,000 children and adolescents in the state of Florida. The CMS Health Plan provides integrated medical and behavioral health services for children and youth who are under the age of 21, who also have serious and chronic medical conditions. The CMS Health Plan goal is really to provide child and family-centered care and solutions, helping children and families realize their full health and wellness potential, and providing, of course, an array of benefits and services that are very easy to use and access. Next slide. So a little bit more about Sunshine Health. The Florida Department of Health actually contracts with Sunshine Health to operate the Children's Medical Services Health Plan, or CMS. Sunshine Health is among the largest healthcare plans in Florida. We offer government-sponsored managed care through a variety of products, namely Medicaid, long-term care, health insurance marketplace, Medicare Advantage plans, and Sunshine also has specialty plans, and those include child welfare, which serves children in or adopted from the state's child welfare system, and the serious mental illness specialty plan for those who are living with serious mental illnesses. Next slide. So the value-based purchasing pilot, some of the factors and considerations that we took into account before embarking on this journey, really first and foremost is our incredibly strong working relationship with the Florida Department of Health CMS Health Plan. That really was a pivotal aspect in getting into this initiative in the first place, and having the wonderful opportunity to work with that team, of course, the GOT transition team as well, all made possible by the Packard Foundation. We also identified some healthcare transition gaps that were occurring with the CMS membership, specifically related to the transition from a pediatrician to an adult primary care provider. This for us was confirmed by some of the physician feedback that we received. We had a lot of medical directors and groups that we worked with really saying that there was a need here for something a little bit more, for a focus around this type of transition. And lastly, we have had prior experience with some transition related work in the past. So we really leveraged that experience that we felt created a foundation to expand into a value-based initiative, around this really important topic. Next slide. So we selected 2 large pediatric offices and 2 large adult primary care sites for partnership in this pilot with us. As far as the pediatric sites go, there were really 3 main pillars for the reasons behind approaching these 2 specific pediatric groups. First and foremost was really the enthusiastic leadership teams that they both had. These are very large pediatric offices who have staff and leadership that were extremely eager to participate with us in this pilot. And of course, their reputation was very positive, and these are well-respected physician groups in the community. I'm sure those of you who have children know that a good pediatrician is not a well-kept secret. So these are really groups that had a nice reputation in the community. And then, of course, mature infrastructure. This was really important to us. These 2 large groups had advanced technologies, the ability to share electronic medical records quickly and easily. Both of these groups had mature policies and procedures and already had some established referral pathways in place. The adult primary care sites that we chose are both federally qualified health centers, FQHCs. These 2 sites have multiple locations and were incredibly convenient to both the site of the pediatric offices and the members that we have enrolled in this pilot. So that was a real plus. They were also very, very excited to kind of embark on this journey with us. So subsequent to the choices that we made in our pilot partners, we ended up scheduling recurring meetings with both of the leadership teams from these 4 sites, as well as the leaders from the key stakeholders in the health plan. We established these meetings on a recurring basis. They really proved to be pivotal in the ability to share information, for the physician groups to provide feedback to us, and for us to be able to, make small changes as we went along to ensure that this was successful. Next slide. So we chose a 12-month pilot, but as Peggy alluded earlier, we have worked for many months kind of preparing for the go-live date of the pilot. So we felt like a 12-month pilot was an appropriate amount of time to facilitate the things that we wanted to put into place, the processes and the standardization. And really the focus that we had with this pilot was to empower the CMS members to proactively manage their own healthcare. This was a huge part of the kind of foundational aspect of what we were trying to accomplish here with 16, 17-year-olds, almost 18-year-olds, really knowing their health state, knowing what medications that they're on, and really being a part of their own healthcare. And of course, we wanted to support families as well with that transition and help support those families and their kids with effective utilization of services, being able to make appointments, being able to remember what they're supposed to bring to their appointments, and really provide support there. And then finally, really the main focus is to get some organized and standardized processes in place with our pilot partners so that we can make sure that planning and readiness of transition is tracked and that ultimately that transition of care is successful. Next slide. So we discussed a multitude of payment methodology options, including per member per month, bonus pools, pay for performance. We ended up going with an enhanced fee-for-service model combined with a direct-to-consumer payment option. The reason for that kind of combined methodology is we wanted to make sure that the reimbursement to the providers was simple, straightforward, and didn't present a challenge to adoption of the pilot program. So we wanted to make this as simple as possible for providers, but we also wanted members to be engaged. So we felt like the direct-to-consumer payment, which for us is going to be a gift card for attending all scheduled adult primary care visits within the first 6 months of their transition, was really a value add to members and families and would help incentivize those members to stay engaged in the process. So some of our measurement strategies and outcomes and expectations of this particular pilot, there's three main outcomes that we're looking for. The first is increased engagement in healthcare transition related activities by both the member, their family, and the physician. We also expect to see an increase in member compliance around their healthcare, as well as a decrease in no-shows and missed appointments. And then finally, we really want to standardize the process around transition related activities and documentation and hopefully scale that up to more and more practices in the future. Next slide, please. So finally, some advice for others, lessons learned. I think we could fill a lot of additional slides with what we've learned so far, but this is really, I think, the most pivotal aspect that we came away from this experience feeling like this was the most important thing to remember. And that's really buy-in, again, as Peggy alluded to earlier, sponsorship from your regulatory partners, from health plan leadership, and especially from your physician group practices was really key. We found that the physicians that we worked with, both the pediatricians and the adult primary care providers, are incredibly engaged and extremely informed and highly opinionated and had a tremendous amount of extremely valuable information to share with us. And key stakeholders is really important too. This can, I think, get lost in translation sometimes, even down to your configurations team, your claims team, having a member of your care management or care coordination team very highly involved in the pilot is just going to increase your buy-in. And then finally, we found that success is really determined, like we said, by appropriate allocation of resources, making sure that there is planning in place, that the scope of work is determined and defined, that roles and responsibilities are clear, and that there's a willingness to commit time and key staff to this incredibly important initiative. So with that, I will turn it back over to you, Peggy, and take any questions.
That's great. Thank you so much, Ray. I think we'll hold the questions until after Aaron has had his presentation, and we'll also be responding to questions that come up in the chat. So Aaron, take it away.
Yes, ma'am. Hello and howdy from Texas. My name is Aaron Head. I am the Star Kids and Star Plus Executive Director here at AmeriGroup. AmeriGroup is a Medicaid managed care organization that contracts with the state of Texas to provide these managed care services for Medicaid and CHIP members. We've been in the state for 25 years, currently serve about 1 million members in Texas, and our reach is across 230 counties in the state of Texas. The products we offer are Star Kids, Star Plus, and CHIP programs. I'll talk a little bit more about what those programs mean here in just a moment. But before I jump into the nuts and bolts of the program, I want to tell you a little story, and I'll be short, I promise, about my first experience with transition. And it was years ago, long before our current program, Star Kids, went live. I was working late on a Wednesday afternoon before Thanksgiving, and as such days often are, it was pretty quiet. I recall dusting my office was on my to-do list that day. The switchboard sent me a call with a frantic parent on the line. Her daughter had just turned 21 in November, would age out of pediatric Medicaid with all its many benefits, transitioning to adult Medicaid in December, which has a much different scope, some might even say narrow scope of benefits in comparison to the pediatric program. Her daughter was not my member in November, and would not be my member in December either. In fact, she wasn't going to be joining my health plan until January. But she called us because she didn't know who else to call. It's important to identify that the pediatric program has unlimited prescriptions. The adult program limits it to 3 unless you're in managed care. So in the fee-for-service environment, this member was looking at being in fee-for-service in December and having a limit of 3 prescriptions per month. And the important note here is that this member, this woman's daughter, was on 9 life-sustaining medications a month. And so she was doing that math that we hear people do all the time around healthcare. You know, what things can I pay for? What things can I let go in order to keep her loved one alive? She was frantic. She was in tears. And again, she was not my member in November. She wouldn't be in December. And so I had no role at this point in terms of handling her transition. And so, you know, there we were the Wednesday before a long weekend, and she was, you know, looking down the barrel of a December transition date and not having the medications that she needed for her daughter. And so I kept her on the phone while I coordinated with my team, coordinated with our state agency and the state's pharmacy, and we got her taken care of. But as I look back on that experience, it didn't have to be so traumatic. Had someone been working with this family, engaged in that transition, this would have been something that got her taken care of long before and never had to be a crisis. In fact, the message that I share with my team is let's take the trauma out of transition. And so here came the Star Kids program. And Star Kids is the program for children with disabilities in Texas in Medicaid managed care. It has a contractual element for transition that I love the fact that that element exists. It requires that transition be part of every assessment, every contact beginning at age 15. So we are, you know, looking forward and laying the foundation for effective transition. But the thing that I feel like the program as it exists in contract today misses is the provider. Everything is member focused. And so when a child graduates from Star Kids, the next program that they might be eligible for is Star Plus, and that is our aged, blind, and disabled Medicaid managed care program. And we know that that an effective transition has so many healthcare benefits, and there are so many changes that occur just in terms of eligibility, in terms of practitioner. One of the things that I grew to learn as we took on this program of Star Kids in Texas back in 2016 was how many members just camped out with their being 21 years old with their pediatrician and with their pediatric subspecialist. So that was something that we certainly began targeting when the program launched, and is something that this program, this pilot program that I'm about to share, focuses on. Next slide. So our pilot, some of the things that we took into consideration beyond my own personal passion for transition was the need to transition from pediatric to acute care. Is something that we know shouldn't be a surprise. The need for transition is like tax day, right? We know April 15th is coming. There's no reason for it to be a trauma. Let's get it taken care of. The Star Kids program addresses this by addressing the transition service coordination beginning at age 15, as I shared. A lot of member-focused activity while very little focused on the practitioner. And as I stated, a more organized approach to transition was clearly needed. Next slide. So when we were building our team, we, including myself, we had director of network management, as well as a manager from network relations, director of quality management, director from product development. Key to our team was the business change manager, who functioned as our project manager in this process. And then we partnered with the National Alliance. And I can't begin to tell you how Peggy and patients have been critical to the development of this program. Concerning the selection of the provider, I looked particularly at who had the membership. We have providers with a large scope of Star Kids members in the state. And then we also looked at who was seeing Star Plus members, the pediatric member and the adult member in these programs. We found a provider that really was a significant provider in both elements. So instead of building a relationship in this program with two or more, we're focusing at this phase of the program on one provider who has both. It's a multi-specialty practice with both the pediatric population as well as the adult population in the members that we're looking to transition. This is a provider that's demonstrated a lot of proficiency in quality programs with us, that has functioned as a partner, that has actually, during COVID itself, did some amazing things in the community. So a very community public health minded multi-specialty group that we feel like is going to really help us stand this up in terms of the initial phase of the pilot. Next slide. So focus and duration, we focused on this time period because we felt that it would provide the appropriate amount of time for a successful transition. And given the complexities associated with the transition, we wanted to ensure that the member had a holistic understanding of and played an integral role in continuing their care into adulthood. So we'll be matching up the efforts that we're already doing with our members in transition, as well as this program that's very provider focused. The transfer period also aligns with other transition age youth focused programming offered by AmeriGroup that contributes to member success into adulthood. And we decided the length of time needed for the pilot was 18 months to allow enough time to schedule the last pediatric visits, the joint visits, and the initial adult visit. Next slide. So I know this is a busy slide, but I wanted to be able to demonstrate here the payment that we're providing to both the pediatric side and the adult side in this program. This is we're reimbursing via our per member per month PMPM distribution. And what we did is we sort of valued it alongside the various CPT codes. And so while we'll be having the provider bill us for encounters, the reimbursement is on that per member per month. One of the things that I'll add while we're talking about payment strategy, key to this is an ongoing sort of account meeting. I would call it a joint operating committee, where we meet on a regular basis, at least monthly, maybe even more frequently, with each of the providers participating at the practitioner level, so that we are sure to be clear on expectations, hold everybody accountable, them holding us accountable, us holding them accountable, and making sure that we're coaching as we go along. You know, our goal here is success. And to do that, we need to make sure that we're talking frequently. Next slide. So my advice for others is to co-opt whatever talent you can get your hands on, specifically your best leaders in your network team, quality management, and elsewhere in your organization. And I highly recommend partnering with the National Alliance. Peggy and Patience, as I said, have been invaluable. They have brought so much wisdom to the table and coaching, and were very gentle in correcting me from time to time. So very much appreciated their engagement on this project. Next slide.
Well, I'll take it from here, Erin. We've just put up a few additional resources that we thought would be helpful to all of you, being this new guide on the value-based payment initiative, the past report on value-based payment, and then a report on Medicaid managed care contract language, and our coding and payment tip sheet that we do each year with the Academy of Pediatrics. So thank you so much, Ray and Erin, for a terrific presentation. I'm going to turn it over to my colleagues, Annie and Patience, to manage the chat here and see if we can't get a conversation going.
Sure. I see a question that can be asked to both the Florida and Texas teams. How have you utilized patient and family partners in the planning and development process? And what will be your plan going forward for including patient and family engagement in this pilot and beyond?
Annie, this is Ray. I think I can answer that. Specifically from the CMS health plan's perspective here in Florida, all of our CMS members are assigned a case manager. So 100% of the members that are enrolled in our health plan are case managed and have a care coordinator that works very closely with them. We have engaged that team, as Erin so eloquently said, co-opting as much talent as we could possibly get our hands on. And they are working with the families and the members who are enrolled in this pilot as closely as we are working with the physicians on the back end. So they are incredibly engaged, very excited about this, and they know all about the program and what the perks are and how it's going to work. And so I think our case management team has had a huge impact on that aspect of our pilot, at least. And we plan to continue doing that moving forward.
Similar over here, you know, our pilot program was very much focused on the provider side of things, because we do have activities going on currently that are member focused. The next level of engagement there then is to bring our transition coordinators into the joint operating committees that we have with the providers. So that is where member voices will be heard most in this pilot program.
I'd also like to just comment that I want everybody on the call to understand that both of these efforts they've just completed their design work. So it's not something that's been operational in the field. So the the questions around what's been evaluated and other pieces like that are not known, but we felt it important to share the thinking of the design construct. And again, this guide is all about the design elements. So, and in each of these cases, when moving to the pilot sites, they're going to form their QI team as well. And again, I know that they've been encouraged to bring in some youth, young adult parent voice as well.
So another question that was asked early on was, what was the funding source for your value-based payment? So can each of the teams comment on that?
Sure. For Texas, in our program here at AmeriGroup, the funding source is the health plan itself. This is a benefit that we're providing above and beyond the benefits for which the state contracts us. So this is essentially a health plan funded project. We're not receiving any additional reimbursement for that.
Yep, and the same is the case for the CMS health plan here in Florida. We are paying an enhanced fee for service reimbursement methodology, and that's not funded to us. That's above and beyond what we're typically reimbursed.
Again, I think it's really important to highlight that we're very early in the stages of this work, and these two MCOs have taken it upon themselves to put their toe in the water. And again, we're hoping that many more state Medicaid agencies and commercial payers see that this is part of a continuum of care for their members, and that it should be part of the fee structure. But currently, we do know that most systems don't have an organized process. And I think many loved Erin's comments, let's take the trauma out of transition. So again, if we can imagine how we're building out a structured process, and it takes resources, it takes an infrastructure, and these two plans are really at the early phases of putting that in place.
I have to tell you, Peggy, that I was traumatized by that phone call that I talked about. And I was involved in that case for 4 hours. I can only imagine the impact to the family stressing through that. And like I said, it didn't have to be that way. And it's our job to make sure that it isn't that way.
Mm-hmm. And, another important piece here is that to engage payers and MCOs, having the voice of the story like Erin just told you, or having the voice of parent leaders. Again, I know in Texas, for example, there's a Star Kids Managed Care Advisory Group, and its leader is a family leader. And they have had a major influence in terms of making transition part of the state's contract requirements, and have been very encouraging of this work. So the voice of the parent in terms of making the case is really important.
So another question that patients just entered in the chat. How will you decide to continue or disseminate this pilot?
I assume the pilot's going to be successful. I just don't see why it wouldn't be successful. In the first phase, working with this one provider group, I really see that as an opportunity to kick the tires, figure out what we're not thinking about. I anticipate this program to roll out to additional practices afterwards. I can't imagine that it won't be successful.
Yeah, I have to agree with that. Honestly, the amount of positive feedback that we've received around the need for something like this to be in place, and especially with the help of the national alliances kind of foundational 6 core elements and, you know, the resources and documents that they have in place. I agree with Erin. I just don't see this not being successful. I think there's really a need for this out there, for more transition age youth and for more practices to have a roadmap in front of them to be able to implement these types of you know, processes into their practices.
I see Alina Chen had a question about the differences in pediatric and adult benefits in Medicaid, and that is something that's generally true across the country. And oftentimes, you know, you're jumping from one MCO to a different MCO. And, you know, the fact that in the state of Texas, you've got AmeriGroup operating in certain counties with both plans is a wonderful potential connector. But I do want to say, though, having the benefit of the leadership of a payer, an MCO, makes so much of a difference on the part of everyone, because you have the infrastructure to know what kind of fixes need to happen in your payment structure. You have ideas about how quality could be measured. You know the network. And oftentimes in our work with Gut Transition, we're in the position, and it's a happy position, to be working with pediatric and adult health providers who don't have the luxury of being the MCO. And so they're doing things on such a smaller level because they have, you know, they're getting certain of their codes are not being recognized. They don't know how to push forward a value-based payment option. So it's really wonderful that we have these two Medicaid leaders, and hopefully we'll get, you know, 20 more or 50 more going forward. We certainly need them.
I think Don Bailey made a nice comment and partial question here. I think this is great work. Thank you, Florida and Texas. We all second that. I would love to see the ongoing evaluations as you implement this project. And I would also ask how you will be looking to evaluate the patient family experience and all that happens with them in the she put in quotes, in between visits, to show if there, whoa, things are moving here, show if there is improved experience and even cost benefits, specifically those with special healthcare needs and complex care. Either of you want to take that on?
Yeah, thanks, Patience. This is Ray. We plan on looking back and asking most likely for a survey from the members and their families on their experience, as well as the physicians. We have a lot of lessons learned that I anticipate that we're going to be reviewing at the end of this pilot and seeing, you know, what worked and what we could do better in the future. So I think that survey is going to make a really big difference as far as the experience is concerned by both the members and the physicians alike.
I would add that, you know, the big success, I think, is the documented visit and repeat visit at the adult site, right? But also we'll be soliciting feedback throughout this project. You know, our transition coordinators will be soliciting feedback from the members. We'll be soliciting feedback and taking temperatures throughout the joint operating committees. So, you know, it is a large continuum of feedback that we're going to be looking for. But in terms of where, you know, I think we're really going to be measuring success in the program is, do the adult visits occur? You know, initial visit, a follow-up visit.
I also think it's the potential of just using, as Erin said, some of your claims data to see the reduction in lapses of care and the movement from pediatric to adult care in a timely fashion is something that's within the realm of reality. There's a lot of additional suggestions in the guide for measurement, and we have many already handy tools that can be used for measuring structure of this use of the 6 core elements, as well as feedback surveys for both consumers, families, and clinicians. So I encourage you to check some of those out. And in the not too distant future, again, with the funding support from Packard, we're putting together a piece looking at a comprehensive view of quality measurement for healthcare transition, which we've done with a national advisory group. So that won't be coming out right away, but there's a lot of options here that Erin and Ray have suggested, as well as some resources in the guide.
Peggy, there's a general question here about whether additional MCOs will be identified, or what's the future here a little bit.
I think that that's a fair question. We have done extensive outreach over the last 2 years. We often refer to it as sort of our dating game with payers, trying to engage them. And certainly with COVID, that's been a challenge. Being the National Resource Center on Healthcare Transition, we're always available for reaching out to us. Again, we had the benefit of a grant to do free technical assistance. But we are very excited to hear about payers and MCOs who are interested in doing more of this work. So here is our contact information, and happy to respond. Is there one other short question, Patience or Annie?
Well, there's one here that says, was there a pause initially in the MCO paying for a first-time visit to primary care long before the standard annual visit would generally be the standard?
I'm not certain the question, but
I know I'm not sure I understand the question.
Yeah, I have an idea about an answer though. It could be oftentimes the initial adult visit is they prefer having it to be a preventive visit. And if the last visit on the pediatric side was a preventive visit, oftentimes what will happen is that that first visit gets kicked out. And again, you don't want to discourage the initial visit on the adult provider side to be kicked out. So again, these are workarounds that if you're an MCO, you can fix it, or working with the pediatric providers, encouraging them to have the last visit as a chronic care visit and not a preventive visit. Again, just a suggestion.
Well, great. I think somebody would very much like to get in touch with you, Ray, from Jack Hat's program. So I'm sure they can do that.
Absolutely. My email is right there. I would invite them to give me an email. That's fine.
Well, on behalf of the National Alliance GOT Transition team, I thank all of you, especially Ray and Erin, for their leadership on this work, and to Holly Henry for her financial support for this. So thanks to all of you, and have a nice rest of the week.
Thank you very much.
Bye.